All right. Okay, let me go ahead and admit everyone, and we'll get started. All right. So it looks like we have guests joining our group. Welcome back, everyone, to our journal club. This month's topic is concussion. So we're going to have Corey, Nicole, and Courtney discussing that with us. Prior to starting, I just want to let you guys know that I am recording this. So if you have any problems or questions with that, please reach out to me directly. We are recording specifically so we have these for future use and for those participants that could not jump on the call today. All right. I am going to start screen sharing, and then we'll get ready for you guys. I don't see anybody else in the waiting room at this point.
Our athletes are leaders and change makers. More than pro players, you're role models for the next generation of athletes. Athletes 11 began with softball last summer. We continue with volleyball now, and look forward to debuting lacrosse this summer.
Right.
Together, we're revolutionizing the world of professional sports. Let's
All right. All right, can everybody see that?
Did you know you could?
All right, Courtney, you and Nicole and Corey are the only ones that should be unmuted unless you self-mute. I'm going to go ahead and pass it over to you guys.
Okay, you can go ahead and go to the next slide. My name's Courtney Washington. I am currently here in a clinic with Dr. James Sterling. I've been here for about 1.5 years. We primarily see concussions and then non-operative orthopedic injuries. I've spent most of my career in college athletics. I came here again 1.5 years ago after having 2 kids and just not really being able to do the college scene with my schedule. I have learned a lot about concussions being here. So it was definitely something that piqued my interest in terms of the journal club. So I'm going to kind of dive into a little bit about some upcoming research that Dr. Sterling has on some trends that we're seeing here in the clinic, and then what a typical assessment here at the clinic looks like with our patients. And then I'll turn it over to Corey, and he'll go over the on-field assessment. And then Nicole will close out with some vestibular therapy. And all of these are connected because this is, you know, the on-field assessment is a tool that the PRN athletic trainers are using. We're trying to make things easier. We're trying to make things more accessible, more streamlined. That filters in here to the clinic once we get those referrals in and we see the patients. And we are able to put in referrals for some concussion management and concussion care if we're not seeing the patients progress in a way that we're pleased with. And that often ends with the vestibular therapy. So that's why we work really closely with Nicole to try and get patients coordinated with that. So next slide. This is my information. If you guys have any questions, please feel free to email me, reach out to me. I'd be happy to answer them. I know that I don't always explain things the greatest, and I'm not the most eloquent person. I'll try my best. But again, if you have any questions or if anything's confusing, just feel free to shoot me an email. Next slide is kind of going into this research. So Dr. Sterling and myself and the other assistant, Jeff Mattis, that's here, we've been inputting a lot of data. We've been collecting data over several years of his patients, and two of these are an article that will be coming out soon. We're still in the data analyzing phase. Everything's been collected, but he's in the writing and in the analyzing phase. So I'm not able to release all of it, but I can kind of touch on two different points that we're really seeing. And it's important to note, we're not telling you anything new. We're not telling anything that you don't know, but the whole point of this is just to kind of streamline things and maybe sum some stuff up into a couple of basic points just to help everybody, especially those athletic trainers that are doing the PRN work. So again, two of the trends that we noticed is the first, the total symptom count, not the severity of symptoms, is a better predictor of this recovery time. So what that looks like is, if you have your typical symptom sheet with your 26 symptoms, it's the total symptom count. So if the patient's coming in and reporting 15, 16, 17, 20, 25 symptoms out of those 26, regardless of if they're rating their headache as a 1 or a 5 or a 2 or a 6, it's that total number of symptoms that we see correlated with that prolonged recovery. You'll get a football player in who took a hard tackle and maybe is reporting a 5 out of 6, but it's maybe just headache and light sensitivity, versus the volleyball player who maybe got lightly dinged on the head with the volleyball and she's reporting 22 symptoms out of 26, and her headache could be a 1, it could be a 5. So based on this model, we're seeing that volleyball player is probably going to take a little bit longer. The second trend is King-Devick test, and the King-Devick test, for those that aren't familiar, is just a reading speed test. We have 3 cards that are laminated here in the clinic, and the patient's just asked to read the numbers on the card. They read them out loud and as fast as they can. So, and we time them. So normal King-Devick speed is generally in the 35 to 40 second range for most of the patient population that we see. I think I can do it in 38 seconds. And that's not factoring in dyslexia or dysgraphia or other learning differences. They have a tendency to be a little bit slower. We also do the King-Devick test on pediatric patients. So, I had a 6-year-old today. Obviously, he read that significantly slower than a 17-year-old. So your reading speed does improve as you get older. And the slower that we see the patients perform on the King-Devick test also has a correlation to longer recovery. So you may get a patient in, a football player in, or a baseball player in, and their King-Devick score could be, 75 seconds or 85 seconds. If they don't have a learning difference, then we're going to want to see that improve. We would like to see it within the normal range, but I'll get into that a little bit later, that it's not necessarily a catch-all in terms of clearance. Okay, so next slide. Just to kind of give you guys an idea of what our typical clinic assessment is here in this specific clinic. Once a patient comes in, obviously we do injury history, we do demographics and vitals. Dr. Sterling is not big on scanning MRI or CT scan of the brain after a concussion unless the parents ask for it. Anytime a parent asks for it, we're never going to tell a parent no. If they're comfortable and they want to pay to have an MRI of their child's brain, we'll send them to do that. If there is a loss of unconsciousness reported, slurred speech, things of that nature, then he'll order an MRI. But for the most part, we don't unless the parents request. We do the King-Devick reading speed examination. We here in our clinic use the sway balance test. If it's our first time seeing the patient, we will sway them twice. We like to take an average of 2. We look at 80 and above as about normal for adult patients, which is 12 to, our adults that we see. The fall risk is a sway balance test where the patient has their eyes open, and we do that for pediatrics and some of our geriatric patients if we're doing a balance test on them. In subsequent visits, we'll only test them once. It's just the first time we like to have an average. We will administer an impact exam. And then once the impact results come back, if they are symptom-free or if their testing looks really good, but they have a red score or a low score in their reaction time, SWAY has an option to do a motion reaction test, and we'll do that if we need to. We like to see patients usually 7 to 10 days for a follow-up. We'll repeat their testing. Some of our patients, we have really good working relationships with most of the athletic trainers at the schools that we see frequently. And so sometimes they'll test at school. So but we will try to do a follow-up if we'll test them as needed. I kind of alluded to it earlier about the Keene-Devick reading speed determinants for clearance. If we're seeing a patient who is steadily improving, but hasn't necessarily hit that 35 to 40 second mark, but again, they're symptom-free, they're steadily improving, their test scores have improved, then we're not going to hold them to that test range for clearance. Same thing with balance. Some people just innately have bad balance, especially if we haven't seen them before. If we don't have a baseline, then we're looking for that steady improvement, not necessarily for them to hit that 80 and above mark. And sometimes if you just explain to the patient, look, this is what we consider normal, especially as an athlete, you have that innate competitive nature. So sometimes I'll tell an athlete, this is what's normal, 80 and above. You're at 78.2. Do you want to try again? And then they'll hit 80. Sometimes you just kind of have to give them that goal for them to meet. So in terms of I touched on it earlier about the learning differences and things, that this isn't new information. Individuals that have documented ADD, ADHD, learning differences, anxiety, depression, migraines, these individuals have a tendency to have a delayed recovery in concussions. We have to factor those into consideration when we're treating them, especially underlying issues that haven't emerged yet. Dr. Sterling likes to use the comparison of a snow globe. And when you have a concussion, it's like you shake the snow in the snow globe. It's all those chemical processes floating around until that last piece of snow settles. You're really not healed, for, lack of a better term. And sometimes when the snow settles, it all doesn't settle in the exact same place that it was before. So it can reveal underlying ADD, dyslexia, migraines, depression, anxiety in some of these athletes, some of these patients, excuse me, because they've always had it. It's been an underlying condition. It's just their body and their ability to cope with it has gotten them up to a certain point. Then you have this dramatic incidence that has occurred. And now we've got to look at some of these other factors. And the vestibular, Dr. Sterling operates as the vestibular aspect of things has a tendency to heal itself. If you're following your concussion protocol in terms of your resting, limiting factors that are causing an increase in symptoms, such as cognitive function, screens, things of that nature, then the vestibular system should heal on its own. That's not always the case. And then when we're having these lingering symptoms with some of our patients, that's when we start looking into referrals. Are they having difficulty concentrating and difficulty remembering? Well, maybe they have some underlying learning difference that they need neuropsych testing to diagnose. Maybe their headache is gone, but they're complaining of dizziness, they're complaining of balance issues, something that's kind of impairing that vestibular aspect of things. Maybe they need to see a vestibular therapist to really stress that and fix that issue that they're having. Maybe they are having lingering headaches. That's when we need to look at a referral to a neurologist to look at medication management, things of that nature. And then the neuropsych testing can also kind of factor in for that depression and anxiety. The largest percentage of population that we see has a tendency to be the private school kids. And there is especially with college prep, there is a higher incidence of that anxiety, depression type of underlying condition in that population versus some of the other schools that we would see. So that's what a typical assessment would look like here in the clinic. We do use other things when we receive referrals. Sometimes we'll have a SCAT test or we'll have a sway test that comes in once a patient is referred, and we do factor that in as well. And Corey will touch on some of that when he goes into this on-field assessment tool that we've worked to adopt. So you can go ahead and go to the next slide, Nicola, and Corey will kind of take over for that.
All right, thank you, Courtney. So here's my information as well for everybody. For those of you who are out there that I don't know, my current role is with Baylor Scott & White Sports Care. Came on board with Baylor Scott & White back in August, and obviously I've been in the area for quite a while. If you do have questions about anything that I talk about or ever need anything, please don't hesitate to reach out. I know that Nicole is going to share this information and everything that we talk about afterwards. So that would be an easy way for you guys to get in contact with us. Nicola, you can go ahead and move on to the next slide. So with this, as I move things on my screen so I can see a little bit better, the Sports Concussion On-Field Assessment Tool is essentially an update to what the athlete training outreach, the Baylor Scott & White Institute of Rehab Sports Health Program is moving towards. Just a quicker sideline assessment than utilizing the SCAT-5. And Nicole, if you can go ahead and advance the slide. So for the athlete trainers who are out there that might be viewing this, we utilize a When I Work app for athlete training program to be able to have some shifts. So I've put some pictures up here just so that people can understand what it's like to be able to find this. We're going to share the PDF, but on the When I Work app, for those of you who are out maybe covering an athlete training shift, this is the way that you'd utilize this. You'd open the app and you'll get to that home screen that's on the far left. In the bottom right-hand corner of that far left picture, you'll see the circles there. You're going to hit the 3 dots. What that does is that advances you to the toolbox that you'll see listed in our middle photo there. You'll scroll down, and then that will allow you to be able to see the documents listed on the app. Go ahead and advance that screen, Nicole, if you would. When you get to the documents, go ahead and you'll go down to the BSW Sports Concussion fillable tool, and then that will open up what we're trying to be able to get to. And you guys can then be able to use the up arrow to send that, utilize that, and it is a fillable document. Nicole, go ahead and advance for me if you would. So when you get to this Sports Concussion on-field assessment tool, this is something that a lot of other people have utilized. And I know from my work working with Mike Harrison at Allen High School, he put together something like this that's gone through some evolutions. When I've worked for other places, we had some things that went through some evolutions. And the being with Baylor Scott & White, I recognize that in trying to take care of kids, trying to take care of an event, being on the sideline, and typically being the only healthcare provider, something that was a little quicker, something that was a little more concise to be able to get the things that we needed was needed. And so working with the concussion program and Dr. Sterling and Dr. Reynolds, we were able to get this created to be able to help have for a sideline assessment. Because it is a trifold, you'll see that this is more of the front and the back. But on the far left, you're going to see the at-home care following concussion. That's something that's going to be important because the way I utilize this is that this is going to be something that's going to go home with the parents. This is going to be something that, when we're going through that assessment, when we're trying to follow up with a parent, we're trying to follow up with someone who is injured themselves, we don't know how much of that information they're really going to be able to take in and digest at the time, especially if we're dealing with someone who has a brain injury. So being able to put tools in their hands is going to help them be able to know what to do and what not to do. And that's where you're going to see on this at-home care following concussion. Nicole, if you can go ahead and go to the next, there we go. On here, I'm going to go ahead and have you guys focus on the far right, which is where the same instances for what to do. We want to identify the red flags, when it's going to be necessary for them to seek emergent care. Oftentimes with a concussion injury, you don't have to do that, but in the situations where we do have those issues, we want to make sure that parents are aware of those. And whenever I'm speaking with a parent, whenever I'm speaking with an adult who's concussed, I always want to make sure and identify those and hopefully have someone there as a caregiver to be able to share this information with right away, so that it helps to put them at ease. It helps them when we're showing up as the healthcare professional that sometimes they don't always know due to the nature of an outreach program. This is very valuable for them to be able to help give them that information and have them be able to reference back to it. On the far left here, you're just going to see a lot of demographic information. And this tool isn't so much different from a standardized assessment of concussion that we've used in the past, a SCAT as it's evolved up to SCAT 5, being able to have Maddox questions, those kind of things. You're going to see that information. But what we're trying to do is get some demographic information, and then you'll see the on-field assessment where we're trying to get mechanism of injury, point of impact. Was there a loss of consciousness? What did we see when we arrived? We can look at balance problems, seizure, length of time. There's a place to be able to document these things. And of course, those are important, especially if we're trying to share this with a provider later. Then we get to more of the Maddox questions, what stadium is this? What month is it? City, the day, who's the opposing team? I don't recommend asking breakfast unless you were there at breakfast, right? So those are questions we stay away from because I don't necessarily know the answer. They can tell me anything. Then we get to the memory, and you'll see on here that it's got time for immediate recall and for a delayed recall. I always use the same words. It's part of my consistent thing. So when you work with a team, you do have to change those up because then they all start to know what those things are. But for me, I always keep it consistent. Then there's also a place here where I can write it down so I can make sure, because if I'm taking care of multiple things, even I need a tool to be able to do this, especially as I get older. So you can also look on here where it talks about asking about, do you remember the hit? What happened before the hit? What happened after? You're looking for retrograde, anterograde amnesia. Months of the year in reverse order. Serial sevens, counting backwards from 7 is hard for a lot of people to do, but hey, what's the last month of the year with Christmas? December. What's the month before that with Thanksgiving? November. Okay, well, what's the month before that? And I set them up with some success to be able to try to get things going, especially with how young some of the kids are that we take care of. A middle school kid who we've never encountered, that we don't know what kind of learning differences they may or may not have, what their academic levels are. I get them headed down that path, but then this is something where I can be able to check off and see how they do. Digits backwards helps, where if I tell them 419, they would tell me back 914. That's a little bit easier again to have some memory things. And then getting back to what Courtney was talking about with the research that Dr. Sterling has going on, this allows us to be able to use a 0 to 6 scale to identify symptoms. This is also very important for parents. It's not just a question of, do you have a headache? That's not how you identify a concussion injury. You're looking for a lot of different symptoms. And being able to let the parents see the questions that we've asked throughout the whole evaluation, but also this and the kind of symptoms that we're looking for helps with that carryover. You'll be able to see that we can indicate the total number of symptoms and the total symptom score on here. There's also room for a neurological exam as part of what we do, and there's a reminder at the end to be able to go back and do the 3-word recall. All of these things are important and valuable, and that's why we want to make sure that we have them accessible on the When I Work app. One of the things that I'm doing right now, as well as some of the other sports care liaisons, is we're trying to get these paper copies out to our PRN athletic trainers, trying to get this to be a tool that can be utilized by the athletic trainers in the schools. And so we're having those interactions to be able to share this information. That's my hope, and being able to just go out, get this out to you all today, is to be able to share this information. And then following everything, Nicola will be able to share this PDF so that you'll be able to utilize this. Maybe you're a physical therapist and you have someone come in for an injury, and then as you go through your history, they start to have some more indications that perhaps there's a concussion injury or something involved, and you're just looking for a tool to be able to help facilitate asking the right questions. This can be useful for that. I appreciate being able to bring this to the table to you guys. Nicole, I think that's everything for me. You can go ahead and advance for Nicole.
All right, thank you, Corey. I'm Nicole. I am a physical therapist at Baylor Scott and White, and I'm in the outpatient clinic at Preston Hollow in Dallas. And I would say just recently, in the past month and a half, I've been working more closely with Courtney and Dr. Sterling. Previous to that, about a year and a half ago is when I moved to Dallas. But before that, I was up in Boston, and I have some experience with Mass General Hospital working with some concussion sports patients as well. So I'm very thankful that I could get in touch with Courtney and Dr. Sterling down here. And I will go over more of the vestibular therapy kind of evaluation, initial assessments that I do here in the clinic. And then along with that, just a little bit of the treatment going off of that. My contact information is there. I know my email is there as well. I know it's pretty blended in with the background, but email is probably the best way to get a hold of me if you have any questions or anything concerning the PowerPoint. Okay, you can go to the next slide. So on initial visit, what I usually look at is obviously subjective reports. So usually I get a report from Courtney or Dr. Sterling, but I like to hear it from their own perspective of what's been going on all the way back to the first visit. From there, I'll talk about what symptoms they have now that are still residual, and get a baseline of headache, dizziness, nausea, all of that. I will go into a VOMS testing, and the goal is to get to those norms, what I have written down there. Now, those are pretty hard for anyone to get to, especially the 180 beats per minute. But if they are trying to get back to an athletic sport, that would be my goal. Going off that, I will do a general assessment with the BEST testing and the Fukuda step test as well. Go to the next slide. That usually, even just subjective information takes a while. So if I can get through all of that and they are not too flared up, I will go further into balance testing, especially dual tasking, more dynamic balance testing. So the DGI, tandem walking forwards and backwards, and then dual tasking while walking. And like Corey said, I usually look at more counting the months backwards or saying the months backwards while walking a straight line more than counting back from 100 by 7, because that's hard for anyone to do. Now, of course, that's, depending on their subjective and objective testing from the last slide, I don't always go from there to here. If they're presenting more vestibular, I'll go here. But the next slide, which you can go to, if it's more of something that's leading me down the cervical path, so say they have more of a whiplash mechanism, if they have chief complaints of, neck pain, stiffness, which is causing them some headaches, which are more the sub-occipital region or referred from there, that's when I will go more, and I'll actually begin usually with a clearing of the cervical spine. So usually you guys have done this by now, but, I'll always do my ligament testing, active range of motion, and joint play, see if I can elicit any of the tenderness, the neck stiffness, see if it's coming more from mechanical, level of a joint or soft tissue that's limiting this range of motion and causing this dizziness and these symptoms. From there, I will do, which is shown on the right there, the joint position error test. So using a laser on a forehead, and then I have that set up in the clinic here. You rotate the body to one side, try to keep your head on that target. This is very hard. especially for someone that's had a concussion. And this is very good at reproducing, giving you objective measurement for that dissociation between those reflexes. So kind of that head stabilization, trunk rotation ability. And a lot of times, not only will they be off more than a certain degree, but this will elicit symptoms like dizziness. They just become very tired, eye strain, things like that. And then, of course, if it's more the room spinning dizziness, that's when you can go into the BPPV testing. And like I listed down there, if these are positive, that's when I will go less vestibular training and more into whatever manual work I need to do here. So if that's mobilization of the cervical spine or any soft tissue restrictions, and then progressing more into cervical stabilization along with restoring those reflexes that are impaired. And go to the next slide. Now, this is something that I will get to probably not the first day, definitely not the first day, as it takes more time and usually is more symptomatic, but eventually, especially if you're getting close to that return to play protocol, I will do the treadmill test. And if they're too symptomatic with that, I can do the modified stationary bike test as well. So research shows, it's pretty safe to do as long as they are 72 hours at least after the initial injury, especially if they're non-symptomatic at rest. Now, if they are symptomatic at rest, I'll usually wait a couple weeks into doing this. But again, research shows that if they're still symptomatic at 2 weeks after, you're still safe doing this test, because it's, you just stop where those symptoms increase. So with this, you measure the baseline vitals, and then I think you might know this program as well. You stop at, increase in symptoms more than, I forget the cutoffs right now, but I think it's 3, or a heart rate more than 80% of max. And off of whatever number you get, how long they can last on the treadmill, I can develop a program kind of getting them back to aerobic conditioning. Now, there are some indications why this would not be warranted, but usually, you want to get these people back to their sports, and aerobic conditioning is a big part of their sport. So just starting off with simple aerobic activity like walking on a treadmill for 20 minutes a day, their body will adapt to that, and then they will become less symptomatic. And goals that you can increase those blood or the heart rate by 10 beats per minute every week and get them back to their max heart rate, being asymptomatic. But again, like I said, that usually doesn't come until a couple visits down the road when I'm getting closer to the return to play. And then vestibular treatments, which is kind of the heart of what I do here. Most patients will at least need a couple of these, especially in the early stages, because usually it's those VOR and the ocular motor deficits that we see here in the clinic. So we start out just with habituation. So just started seated VOR at the speed that they can do that keeps them asymptomatic. And then as they get back up closer to that 180, you can challenge that by standing, and then of course making those environments busier, more lights, more people around. You can do this walking, things like that. If they have more ocular motor retraining, this is usually harder. These patients usually progress a little more slowly, and you start with what's called pencil push-ups or using Brock strings, which are the picture to the right there. Just trying to them to get their gaze back, basically. And sometimes I'll give VOR exercises with that. Sometimes I will wait until their ocular motor function is a little better and more stable to then progress to VOR. Another thing I like is using phone apps. Now, I know usually post-concussion, you want to stay off your phone, but I will tell them, and I'll tell their parents too, usually 5 to 10 minutes a day, give them their phone to go on to a couple of these apps I have, which if anyone wants to know what apps they are, I'm more than welcome to share those as well, but they're actually pretty fun and the kids like doing them. So it's a good way of retraining the ocular motor function as well. And then of course, balance training. So again, starting more static in a stable environment and then progressing to unstable, dynamic, more sports specific and head rotational movements. And then, like I said, sports specific. So if that requires ball tossing, kicking, with cheerleading, it's more of getting the head movements in and those faster plyometrics in. But of course, that's way down the line in the return to sport protocol. So this is usually where I spend most of my time. But occasionally, like I said, there is someone that needs more of the aerobic retraining, and there's some people that need more of the just cervical treatment because of a whiplash incident or something like that. But yeah, I think that is for the most part all I have as well. So if we want to turn it over to any questions anyone has, or we might have a couple of discussion points.
All right, yes, we do have some discussion points. Let me stop the screen share there. That's great information, guys, because it helps to understand and be able to educate your patients and their parents and their coaches on what the symptoms mean, what they look like, and who we have to refer to. So always know that the doctors that we have on staff are available for everyone. Our sports care reps are great at getting you in. And then we can kind of be that liaison for everyone. Let me pull up those questions real quick. All right, that doesn't want to do that. Let's not do that. All right, so first question for the group, and you guys can just unmute and chime in, or if you want to type in your answers if you're not in a space where you can speak freely. The first question is, what symptoms are more important or emphasized more in the clinic?
So, obviously, probably number one symptom that everybody is going to recognize is the headache. And so a lot of what we do in terms of how we're progressing a patient with a concussion is centered around that headache. You get kids that have chronic history of migraines and who, if you baseline is important with those kids, because I can't tell you how many times we pull up a patient's baseline and they're reporting a 4 out of 6 on a headache at their baseline. You should be symptom free at your baseline. But at least that allows us to compare that and to notate that. We will, if a patient is progressing really well, their testing has improved, their impact test is in normal range, but they're still reporting maybe like a 1 out of 6 fatigue or mental fogginess or, some of the lighter symptoms, but they have no headache, then we'll let them start their return to play. If we also have some patients that, are taking longer than average. So average for male is 21 days, for female is 28. So maybe we're having that they're going a little bit longer than average. They're doing vestibular therapy. We've treated with prescription medicines for the headache. But we're seeing more of symptoms of anxiety and nervousness, or maybe they just don't test well. Some people just don't do well on the impact test. They get too anxious about the impact test. That we take those case by case, but we will let them start return to play and just see if they have an increase in symptoms. Nicole's actually seeing one of our patients right now that's in that boat. She gets very nervous and very anxious when it comes to the impact test. So she's also got a lot of anxiety about wanting to go back to cheerleading. So we're letting her go back and we're just kind of monitoring her symptoms, and we work really closely with the athletic trainers at those schools.
Good, that's great. Is there anything in particular for the athletic trainers, especially when they're working with students maybe they don't have a baseline for, that would be good questions that we wouldn't typically ask to kind of help us to determine some of those baseline statistics as we're filling out those reports and as we're referring students?
Some of the big questions, and I don't, this actually just even occurred to me too, that we can include in that SCAT or in the fillable concussion tool, history of ADD, ADHD, or dyslexia, dysgraphia, other learning differences, anxiety, depression, and migraines. And then in the clinic, if the kids tell me no to everything, and I will ask them like any family history of anxiety, depression, or migraines. Sometimes they'll know, or sometimes mom and dad will know. Well, actually, you know, my mom gets migraines all the time, and she sees a neurologist, or you know, my grandfather has depression, or my dad has depression, and so forth. So those are just a little bit of some family history for us to keep in mind, because again, there's a genetic component with that. And so when athletic trainers are asking those questions, those things are important to note. History of learning differences, migraines, because maybe the kid is telling you they have a 6 out of 6 headache, but normal for them is 3 out of 6. So that's a factor to consider.
All right, great. Let's go on to the next question if no one else has any questions there. Our next question is, are previous concussions taken into account in the history? So I know we ask this as athletic trainers. Is this something that's relatively important when they're coming into clinic, whether it's for vestibular therapy as they've moved past, or if they're doing just traditional concussion therapy?
Mm-hmm. So when they're repeat patients here in the clinic, we do compare their recovery rate from the previous concussion, and also what we did. You know, we will get a patient in, oh, last time we saw them, they took 6 weeks to recover. We did prescription medicines and we did vestibular therapy. They responded well. Well, instead of waiting 2-3 weeks in, go ahead and hit them with the medication and go ahead and hit them with the vestibular therapy. It worked in the past, so there's no reason why it shouldn't work again. Again, everybody's different. Everybody responds different. Some people, because when it turns into their 2nd, 3rd, 4th concussion, now we're looking at prolonged recovery rates. And that is something, as long as you're upfront and honest with the parents about it, I think that's the biggest thing, is communication.
Yes, definitely. The more we can communicate, the more that it eases the mind of the parent, and it kind of helps them understand how their child is healing and what that looks like. And so being able to bridge those gaps is a great thing. The next question is focused on BEST testing, or something similar to that. Is there a good standardized test like a BEST or balance that's comparable to use instead of sway, since not everyone has access to the sway balance system?
I mean, you just have to use what you have. On a sideline assessment, to be honest with you, it's more of asking the patient, do you feel off balance? Or, as Corey kind of alluded to, are they kind of stumbling off the field or off the court? You're not, even if you had a baseline BES test and you had a baseline sway and you're using that to compare, you have to always factor in that the reliability of different professionals using those tests. So maybe someone else did the BES test and I'm doing the BES test. We're not going to grade them the same. Sway at least is the app, and you use your phone, so it takes a little bit of that out of it. But when they did their baseline test, was it in the morning? Had they eaten breakfast? Were they wearing their shoes? What kind of floor were they standing on? You know, did they use the bathroom before they took the test? I mean, there's all these different factors that can change up a person's balance. And so you have to use what you have. But and that's why we don't put all of our eggs in that basket for clearance. We try to hit that 80 and above mark, but if we don't get there, all of the things looking good and we're showing a steady improvement, then the clearance is not going to hinge on what their balance looks like.
Okay, great. That's good. I know there's a lot of inter-rater error with those BEST tests, so always trying to find, and I personally use sway and I love it, so I advocate for it a lot. But I know, coming from the high school, middle school they're not always financial means for that. So it's good to know that we can use those comparables. Our fourth question here, what if the patient does not have a baseline impact, again, or a balance test that is that baseline? How can we be comparative with that so that we're showing good diagnostic measures as we refer them and diagnose them acutely?
Well, here in the clinic, even though we don't have baseline impact test on some people, we do have parents that call and schedule baselines for their students, which is helpful for those that want it. Otherwise, we have access to normative data, and so we compare, which is for their age group. Dr. Sterling also has access to that data for individuals with learning differences. So that way we're at least comparing, you know, a 14-year-old male with ADHD to other 14-year-old males with ADHD in that bracket versus somebody that doesn't, you know, factors that don't fit with that.
Good. And do you see any difference in comparison? I know we focus a lot on learning disabilities and ADHD and conditions like that. Do we see anything if someone is on like anxiety meds, things like that, that would exacerbate symptoms and possibly, or even cover up symptoms that we're not looking at because of those?
Yes, and that's one thing to factor in is what prescription medications do they take on a regular basis, and did they take it prior to the test? So, you know, you get kids that, oh, well, I did my baseline, but I forgot to take my ADHD medication. Well, you know, those are all going to be things that hinder it. And the good thing about impact is you can actually correct a test. So let's say you've got a patient that took their baseline 5 years ago. They didn't take their ADHD medication. They've had 2 concussions since their baseline. Well, as their score improves, once we get to the point where okay, this test score we're going to use to clear you. Well, now we're either going to have you repeat your baseline or we're going to make this test your baseline. So that way, moving forward, we will always compare. God forbid you have another concussion, but we'll compare it. We have a new baseline for you. So you have the ability to do that. The same thing with the anxiety medications. You want to find out, did they take them before this post-injury 1 or 2 test? Is that why we're seeing an increase in that? And the only way to find out those types of things is to sit down and have that conversation with the patient or the athlete.
Good information. The last question here is kind of referring to baseline testing. So we all are aware of the impact testing, but what about the C3 logics? We've been seeing a lot coming out for that lately. Is that a good comparative baseline if we're looking or shopping for different things to use in our clinics and in our schools?
I know the draw for C3 logics is because it's kind of everything all in one bucket and all in one toolkit. And again, you just got to use what you have, whatever selling point you can for your schools or your organization. And it's helpful to have baseline testing. It's not completely necessary. I'm not as familiar with C3 logics as the ins and outs of it as I am with impact. So I know that we have normative data here in our clinic for impact. I'm sure that there is some out there for C3 logics, but we don't specifically have access to it. So all of our concussion specialists at, you know, our locations through Baylor Scott White are using impact.
Good. All right. And then I have one last question that wasn't on the question list that I thought of, and it's really for the whole panel. If we're seeing a student athlete and we're referring them in either to your clinic, Courtney, or your clinic, Nicole, or even as it's coming to you, Corey, through sports care, how long is that referral? What does that referral process look like from the athlete and the athlete's parent side? Because, you know, we pass it off, and if we're not hand in hand with that student because we're not there with them all the time, how can we explain that to mom and dad and coaches and kind of let them know, what does this look like? What does the typical timeline look like so that they understand a little bit better?
I'll take the start of that and then I'll let that go across the board. So for me, a lot of times parents don't necessarily know how to navigate the healthcare process. And that's what my role is to be able to help answer questions as an athletic trainer, as a healthcare provider, and then be able to get them pointed in the right direction for their needs. So when it comes to a concussion injury like this, what I'm oftentimes going to do is I'm going to reach out to the office that best fits them, based on where they live, what they need, what's going on, and then be able to help facilitate the schedulers at that office to reach out to the parent to be able to get things taken care of. Sometimes it's nice to be a middleman, sometimes it's not, right? I don't know what the parent's schedule is with work and everything else to be able to get to an office, and I don't know what the schedule at the office looks like that for that day. So I want to make sure and kind of remove myself out of that process, but at the same time lead them, and educate them why I'm leading them in that direction. People have lots of choices, and we want to make sure that it's the best fit for them and take care of the patient first. So a lot of times that's my relationship with Courtney and Jeff and Dr. Sterling at the office to be able to say, hey, I've got this, and handing it off so that they can get it scheduled. I do the same things for the PT side, but I'm gonna let both of them kind of talk about what that looks like in their offices.
So in terms of our side, if we're getting referrals from sports care or from schools that we work with on a regular basis, they're often seen same day or next day. Not necessarily same day of injury. Of course, if a kid gets a concussion that morning, we're not going to bring them in that afternoon and test them. Their symptoms are going to be off the chart. So we like to at least bring them in the next day. But you always get the weird case of, hi, my kid got a concussion 4 weeks ago and they're just not feeling better. And can we come in today? If our clinic is slammed, that person's probably not coming in that day. So it's a little bit of give and pull. We work really well with the athletic trainers at some of the schools that we see on a regular basis. They can often administer the testing. We could do like a video visit. We have that capability. Impact Now can even do baseline and post-injury testing remotely, so we can test them remotely and do a video visit. I mean, there's a lot of different tools in our tool bag that we have to use, and we work really closely with, again, the athletic trainers and the sports care reps. So it just depends.
And then as far as here in the clinic, Courtney does a pretty good job of, she's always been giving me a heads up, hey, we're sending a referral to you guys. Not everyone that goes to Courtney and Dr. Sterling will need to come for vestibular training, but when they do, we'll receive that referral, and I try to get them in for their first visit here within definitely that week, usually 1 to 2 days. And then usually if it's just strictly vestibular training, I can give them some exercises to do at home for that. And I don't need to see them usually more than once, maybe twice a week in the clinic. And saying all goes well, hopefully within a month that, they have no symptoms at all. And I communicate with Courtney on that and tell the parents that we're communicating on that. So, they get a pretty good idea that we are in close communication with each other. So that's that.
Great. All right. Well, thank you so much, guys. Nobody else has any questions from the panel. Like I said at the very beginning, we are recording our sessions now. Yay for that. One fun thing coming up, I have scheduled a CEU session with Dr. Reynolds. This was originally scheduled for during the Snowmageddon, and now, snow, so we're not going to do that. We're pushing it to Wednesday, March 10th, but it is the new science of sports concussion, the clinical profiles and targeted treatments and active recovery. And so that is going to be worth BOC CEUs is one CEU. Hopefully you guys have all gotten that updated registration link and schedule. If not, I'm going to attach it to my update for today that I send out with the group's information. So you guys feel free to pass that along to anyone you think would be beneficial to get on that call. It'll be a 1-hour webinar, and that will also be recorded, so we have access to it at later points as well. Next month is March. We're going to be looking at AT advocacy. March is National Athletic Trainers Month, so if you didn't know, now you know. Please share some love to your athletic trainers that are around you. We'll be looking at advocacy topics with that group. We are kind of doing an open forum right now and switching to a more journal based. So there may be some items coming out that you should review prior to our call in March, but you'll have information and updates on that via email as normal. So if anyone doesn't have any questions, then thank you all for presenting today. I think it was great information. Hopefully it's very useful for everyone. I will include their contacts in the update email after this conversation. And you guys have a great rest of your day.
Thank you, Nicole. Appreciate
Thank
it.
you.
Thank you.
Thanks. Bye, guys.